morning to all. At the outset, I'd like to thank AIOS and the organizing committee for giving me this opportunity. So I'll be talking on cataract surgery in coloboma and microcornea. So as we know, coloboma is a failure of the embryonic fissure, and cataract generally develops at an early stage. We have very hard cataracts, zonular weakness, poorly dilating pupils, and also the biometry is quite difficult in these cases, and the working space is limited. So your surgical planning has to be meticulous. You must have high molecular weight OVDs, vitrectomy machine, knowledge of SICS is also important, and importantly, capsular supporting devices. Choice of IOL, again, in our experience, we have seen that you should avoid very large plate haptics and 4-aptic IOLs because the trailing haptic, it tends to tear the rhexis margin when you enter in. So this was a study done at our center, about 280 eyes. So whether you do SICS or phaco is an individual choice, but normally if the corneal diameter is small and the cataracts are harder, it's better to do an SICS. Whether relatively softer cataracts and larger corneal diameters, it's good to do a phaco. So this is the first case. You can see a hard cataract. So we tend to make both the side ports initially because we expect a vitrectomy might be needed. Then a phonic space flap and a large scleral tunnel is made. In this case, the internal dissection is very important, and the internal tunnel should be, and you can see that large zonular dialysis there pre-existing. A large rhexis must be made, especially in the superior side. The nucleus is prolapsed out. So in this, don't prolapse out the whole nucleus because the space is limited, and then a gentle delivery is done. Again, we do a bimanual in this because we have a phaco machine available, and take the cortex in the colobomatous area last of all. CTR is implanted with a bimanual technique. Another important thing in this is to do a bimanual implantation of the IOL as well, so that the leading haptic, it goes into the bag. So you can confirm this. So this is another case, a relatively hard cataract, small cornea, very shallow AC. So capsule is stained. Again, a large tunnel must be made. And side pocket dissection is very important in these cases. So in this case, I decided to put iris hooks because the pupil size was small. And again, the rhexis was made. A large rhexis is aimed at. Hydrodissection is done, the nucleus is prolapsed out. You must remove the iris hooks before you do the nucleus delivery, and a traction from the rectus is very important. Again, the IOL in the bag was implanted. So since the tunnel was slightly on the larger side, I decided to suture it. So this is another case. You can see the cornea size is good and the cataract is relatively of a lower grade, so decided to do a phaco in this. So the incision should be slightly limbal in this case. And the trick is to complete the rhexis in the colobomatous area last of all, so as to avoid extension and have more of the ripping forces when you're making the rhexis. So adequate rhexis was there, hydrodissection is done. So the surgery has to be slower as compared to the normal cases, and a modified stop and chop was used. And one pie is removed to make space in the bag. Again, cortex aspiration, very gentle, and last of all in the area of zonular weakness. In this, there was no zonular weakness, so decided to go ahead with the IOL implantation. But the key here is orient the haptic in the area of the zonular weakness. So this is another case. So you can see there is a pre-existing 3 to 4 hour clock hour zonular weakness, and NS3 grade cataract is there. So in this, the rhexis is initiated with a cystitome because the capsule is very lax. Again, I completed the rhexis last of all in the area of coloboma. Hydrodissection is gently done and rotation. So in this, I decided to implant the CTR before going in for the phaco to stabilize the bag. Again, modified stop and chop was done. And your parameters, you have to slightly adjust them. Bottle height has to be decreased because you already have a zonular weakness sitting there. And you also have a fluid misdirection in this if you have a too large bottle height. So before exiting the probe, put in the viscoelastic. And then again, the cortex is aspirated. Last of all in the colomomatous area. And a single piece lens is implanted. Haptic is again oriented in the area of the zonular weakness. So this is another case. The cataract grade is slightly more NS4 and there is a 2 clock hour zonular weakness inferiorly. Slightly larger axis is aimed at because you might need to convert to SICS if a complication occurs. Again, a hydrodissection is done. And always ensure that free rotation of the nucleus is there, otherwise you will have complications. In this we do something known as the crater and chop, whereas a crater is made, the first chop is achieved, and the chop is done, and the phacoemulsification is completed. Again, cortex aspiration is the same. So in this I found the bag laxity was there, so CTR was implanted after the phaco was completed. So it should be started opposite to the area of the zonular weakness. Again, a handshake technique is adopted. And the CTR is implanted and finally the lens is placed in position. So this is the last case, this is a post-retinal detachment. Colobomas tend to have retinal detachments and you can see silicone oil inside there. Silicone oil is washed out. This is a very soft cataract, young patient, extremely difficult to manage sometimes with the epinuclear plate sitting there. So hydrodelineation was also done. Not much phaco energy was needed, but I had a lot of struggle. And finally the epinucleus was removed, cortex was removed, the pupil size had gone down, so, and the IOL was implanted. So the key in these cases is meticulous planning, choice of the surgical procedure and the capsular support. So you must know when to implant the CTR. It should be as late as you can, but as early as you must. Thank you very much.
Thank you very much. Very nicely depicted videos, but 2-3 points which you can add is, one is these are very small eyes, so it makes sense to decompress the vitreous before we start the surgery, which you must have done, and also to inject viscoelastic in that area of zonular dialysis, because that will plug the vitreous and fluid misdirection can be avoided. These are some things
and we don't tend to use dye in all cases because it goes into the
dye will go behind and red reflex will go. Yeah.
Thank you.
Thank you very much. Very nice videos.